Welcome to Three Plastic Surgeons and a Microphone. This is our 12th show, and today we are going to be talking about rhinoplasty. We have, as always, Dr. Sam Jejurikar from Dallas, Texas. His Instagram handle is Sam Jejurikar. Dr. Salvatore Pacella from La Jolla, California. His Instagram handle is San Diego Plastic Surgeon. And
West Coast, baby.
That's what all the surfers do when they're out there.
Yeah.
And then I'm
locals only, bro.
That's right. That's how you recognize the locals. They do that to each other. And then I am Sam Rhee from Paramus, New Jersey, and my Instagram handle is Bergen Cosmetic. Remember, this show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based on circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in the show. So with that, today we are going to be talking about rhinoplasty, and I will give it up to Dr. Sal Pacella to begin talking.
Good morning, gents. How are you both?
Doing wonderful, Dr. Pacella. How about yourself?
It's fantastic. It's been usual sunny and hot weather. How's everything going? Did you get hit by any hurricane there, Texas, Sam?
We got very, very lucky here in Dallas. The hurricane veered off to the east before we even got any remnants of it. I think I got about 3 drops of rain on my grill in the backyard, and that's all that I noticed from the whole thing. Yeah, we got very lucky.
And Dr. Rhee from New Jersey, how's the Jersey Shore?
Everything's good here on the East Coast. Nothing unusual. We're just getting geared up to get back to school and with the kids and sort of dealing with that right now.
Yeah. Good. All right. Well, welcome, gents. So today's podcast, we're going to talk about something a little bit different that we haven't spoken about previously, and that's about rhinoplasty, also known as nose jobs to the general community. And this is an area of the face and of the body where arguably function interacts with form and cosmetics more than any other place in the body. I mean, it is a exceptionally challenging operation, and I would say that most surgeons that I know have given up rhinoplasty in their practice early on. Texas Sam or Jersey Sam, any comments on that?
I definitely haven't given it up. I think there are people that specialize in rhinoplasty. So in most large cities, there are rhinoplasty surgeons that's really all that they do. In fact, one of my partners is a internationally famous rhinoplasty surgeon. But it's true. Of the 11 guys that are sort of affiliated with my group, probably 5 of them perform rhinoplasty. The other ones have just gotten far away from it because it's such a different skill set than other things we do in surgery.
Absolutely. I think it's one of the most dramatic changes that you can make to the face. It's one that, as Sal in San Diego has said, is so functional also, as well as aesthetic. And for me, I still do rhinoplasties, but I know what I can do and I know what I can't do. If there's a complicated redo or a multiple, someone who's had multiple operations on their nose, I will send them to one of the specialists that Dr. Jejurikar has mentioned, someone who has a lot of experience. If it's something I feel very capable about and that I know I can achieve a result with, I will do it. But I definitely pick and choose what I know is within my skill set.
In Manhattan or in northern New Jersey, do you see this as a very popular operation?
Yes, there are a lot of people who. It's funny. There are probably more people interested in rhinoplasty than actually get rhinoplasties. I see so many patients who are interested in it, not sure whether they should proceed with it, and then at some point do it. It's something that they circle around for a real long time sometimes before they actually do it.
Yeah. And the thing I find at my practice in San Diego and La Jolla is, we have a huge population of patients that have both functional and cosmetic concerns. And what I tell patients is, I give them this simple analogy. Anything you do to change the function of your nose can obviously change the aesthetics of your nose. For example, let's imagine you had the biggest nose in the world with massive nostrils. And if we wanted to reduce the size of that nostril, you can easily see how that would affect the airflow through the nostril. Obviously, you're breathing through something this big compared to something that big. Consequently, let's say you had a very small nose and we wanted to expand the nose. If your nose was just simply removed and you're breathing through a hole in your nose, obviously you could see how that would affect the cosmetics. So it's just absolutely critical to not underplay this concept of function versus cosmetics. And those are two fundamentally different things. Sam and Dallas, what your thoughts?
I think that is a beautiful analogy. I've actually never heard that before, but I think that's very apropos. It's very true. I think this operation, more often than not, the people that come into my practice, I'm going to imagine the same is going to be true in San Diego for you, Dr. Pacella, and in New Jersey for you, Dr. Rhee, is people want their noses in general. They're coming to us for the aesthetic aspect of it, and they're not thinking so much about the potential consequences in regards to their breathing. And it's not just the nostrils, like you mentioned. There's the septum, which is an area people don't traditionally see. There's a thing called the internal nasal valve, which I'm sure we'll touch upon later on, which is higher up in the nose, which can be a source of issues. And trying to create that balance very much can sometimes go against their primary reason for being with us, which is to improve the reason, to improve the appearance of their nose. Just out of curiosity, before we move on, do you guys see in your practice a large demand for non-surgical rhinoplasty, Dr. Pacella? In San Diego, is that a popular thing?
I do, actually. As part of my affiliation with MD Anderson and also being part of a large multi-specialty group with head and neck surgeons and otolaryngologists, I work with at least 10 to 15 ear, nose, and throat doctors. And just for our listeners out there, an ear, nose, and throat doctor is a physician specifically trained in diseases of the nasal cavity or airway or throat. And so these types of docs oftentimes get referrals for nasal airway obstruction. And when patients come in, they ask them questions. Hey, well, what about this hump on my nose? And many of them don't feel comfortable addressing the cosmetic aspects. So I get those. I do serve those patients for both functional and cosmetic reasons. But on the consequence as well, being a cancer reconstructive doctor as well, I do take care of a fair amount of patients that have really bad noses from the functional standpoint, either from trauma or nasal reconstruction. So that is a fair large chunk of the rhinoplasty patients I see. Cleft lips. Cleft lip patients, rhinoplasty, etc. So,
Yeah.
Well, why don't we dive in here to the case here? So I'm going to share my screen here. Okay. Oh, you got it up. Okay, great.
Mm-hmm.
Hold on a second. Sorry, gents.
No problem. While Sal's doing that, I was just going to comment on non-surgical rhinoplasty as well, Sam. Yeah, that's been a growing part of my practice too. For people who are looking for relatively minor changes, it can be a very powerful tool. They hear a lot about liquid rhinoplasty or, something term similar to that. And that's a pretty easy, not easy, but a relatively non-invasive way for people to change their appearance and see whether changing their nasal appearance is something they really like to do.
Yeah, the reason I brought that up is I've seen a huge increase in demand for liquid rhinoplasty and for relatively minor touch-ups. Like in the last month, I've had no less than a half a dozen young women who were getting ready to go to college who wanted a little change before they went to school. So just curious if you guys are seeing that same trend in other portions of the country.
A little bit, yeah.
Yeah.
All right, great. Well, okay, let's you okay with sharing the screen there?
Yes.
Okay. All right. So we have you can see my first slide here.
Yes.
Okay, so nasal surgery rhinoplasty. So I want to show you a very challenging first case here. Okay.
Woo!
That's an oblique view of Dr. Pacella.
Oh,
It's an Italian schnoz. So obviously, we're with levity here. So this is an operation, obviously, that is, arguably no other area of the body is smack dab right in the middle of the face. And there is a reason why I love performing rhinoplasty so much. And the main reason is its interplay with the eyelid. Being both a reconstructive and cosmetic eyelid surgeon, this goes part and parcel to the same thing. When we're talking with people at a conversational distance, really when it comes to focusing on that person and speaking with that person, the eyes and the nose create a huge interplay. This is a attractive young lady here. And if I just showed that slide to you, where are you going to focus your conversation on looking at this woman? You're going to focus right here. And that central triangle of the face is so critically important to communication, to human interaction, and any degree of deformity or shape disturbance in the nose can interplay with that human interaction. Gents, your thoughts?
absolutely. I think that's one of the reasons why masks are so
It's tough, yes.
difficult in terms of human interaction, because you would think the eyes would be enough to react with someone, but no, you need that lower part of the central triangle to really feel like you're connecting this with somebody.
That's a great point about the masks.
Yeah, no, it's so true, and I like how it looks like it's an equilateral triangle the way you have it as well, because that really are the ideal proportions. The nose fits in nicely between the inner portion of each eyelid, and if it's off, and if that balance is off, the whole facial balance is off.
Right. So this is our patient here. So she is just as an intro here, this is a very nice young lady, 23 years old, who came to see me, referred from her otolaryngologist, or her ear, nose, and throat doctor, had a significant amount of nasal airway obstruction, difficulty breathing. She was a bit of an athlete. When she ran, it was very challenging for her to take a deep breath, but clearly also did not like the cosmetic or aesthetic appearance of her nose. And let's hand it over to you guys. Tell me, what you see here and what your thoughts are on her nose.
I'm happy to go first. So, this is very typical of many of the noses that we'll see. I basically will group rhinoplasties into being two categories: rhinoplasties where you want to make the nose smaller, and rhinoplasties where you want to add to the nose and make it bigger. And in different ethnicities, you tend to have a predilection of one type versus another. In this particular case, when you look at this young lady, the thing that you're drawn to more than anything is what we call the dorsal hump. So the portion of her nose, which is a portion of which is bony and a portion of which is cartilage, doesn't have balance compared to the rest of her nose. So I know this is something that she brought up to you when she first came in. The other thing that you look at when you look at this young lady is that overall her nose just appears long. When you look at where the tip of her nose is, and you think about the angles you wanted to have with her face, the nose is plunging or going downward. So the steps that we take during surgery are going to be geared largely towards raising the tip up and reshaping it, and also reducing the size of the upper portion of her nose.
Absolutely. One of the things that we did in training, and that we all learned, was how to do a facial analysis and how to evaluate the proportions of the nose. And this is one of those things that we had a lot of training, and we could literally talk for an hour about the facial analysis and the nasal analysis in a patient. It's super technical. It's not something that I think patients would necessarily be interested in. But you could certainly talk a long time about about breaking down the technical aspects of it. The only other thing I would want to comment on top of what Sam said, though, is it looks like she has a little bit of a C-shaped deformity where the nasal bones are angled a little bit off to her right.
Mm-hmm.
But everything else Sam said was spot on.
Right. So, Jersey Sam, that is very correct and astute of you. So you can see here, just the entire nasal platform is shifted off to the left here, and that's a challenging thing to fix. Oftentimes, what I tell patients is, and in fact, let me go to the next slide here. So these are a couple diagrams that appeared in my textbook, Aesthetic Facial Reconstruction After Mohs Surgery for Nasal Reconstruction. But I think they're excellent diagrams to talk about cosmetic nasal surgery. This gentleman who's in this photo is my good friend, Rob Heidger. I brought him into the office one day. He's one of our reps for breast implants. And I said, "You want to be in a textbook? Come here, take a picture." So we did this little overlay on his nose. So what Jersey Sam is referring to here is there's an interplay here between the bony aspect of the nose and the cartilaginous aspect of the nose. And a common misconception that I had when I first started studying nasal anatomy is, well, this area of the nose called the nasal ala, the bottom or rim portion of the nose, you would think anatomically that there's cartilage down there, but there actually is no cartilage whatsoever down there. All this is a tube of fibrous tissue with fat surrounding it. It's very much like a PVC pipe. PVC pipe underneath the sink. And what I tell patients is, when there is a break in that a PVC pipe is very difficult to bend. You cannot flex it very much. If you take it and pull on it, very difficult to change shape. But as soon as you cut a little tiny hole in that PVC pipe, all of a sudden there's a fracture point, a weakness, and that can bend. And that's why it's so critical to understand the anatomy of this area, because if we start cutting into this area for functional or cosmetic reasons, and this fibrous tube is disturbed, all of a sudden that fibrous tube can collapse, and that can cause devastating nasal airway obstruction. And going back to this gal here, if you look at her skin, okay, so let's just look at the base view. This is what we call the worm's eye view of the nose. If you look at the distance from her tip to this base of the ala, which is the side of the nose, do you guys appreciate how this is smaller, shorter than this side?
Yes.
Yeah.
Right. So we can do everything we can to reconstruct this nasal cartilage right here and get it absolutely pencil perfect within fractions of a millimeter. But sometimes the issue is this soft tissue envelope of the skin. For 23 years, her nose has been redraped over this cartilage that has been short. So guess what happens to that skin? That skin has contracted. So the skin has some inherent memory to it. And when we put the nose back together after reconstructing the cartilage framework, that skin wants to go exactly back to the position it was in. So we have to oftentimes do some maneuvers to mitigate that. So, gents, any comments on that?
It's one of the ways that we all learn to think about the nose, which is not as popular anymore, but I think is very apropos for this example, is to think of the nose, and particularly from the worm's eye view that you have illustrated here, as a tripod. There's essentially three legs of the tripod, one being the right ala or the right nostril rim, one being the left nostril rim, and the other being the septum right here. And much like a tripod, if one leg is extended further than the other, the whole nose will shift. And so Dr. Pacella is right in the sense that even though there is a fibrofatty framework only along this outer portion, sometimes to fix that, you have to add cartilage to actually give support to the skin where there wasn't any before. And so it'll be very interesting to see what he actually did to straighten the nose. And going back to the fact that her overall nose is crooked, there's a multitude of reasons why we see that. It's not just the bones you see on the outside. I suspect that when Dr. Pacella did her surgery, her septum was quite long as well, and that curvature is contributing to that imbalance of the tripod.
It's funny because a lot of patients, or if you just looked at her, most people would say, oh, she has a huge beak to her nose and you just got to shave down that big hump. But I know the minute I saw her and I saw that worm's eye, I said, how is Dr. Pacella going to manage the tip? How is he going to support it? These are the sort of technical aspects. How is he going to shape it? Those are the technical aspects that make rhinoplasty so complex. And very artistic, because there are probably 15 different ways you could approach this, 10 of which would be perfect, 5 would be adequate. And, and that's something that is a constant learning challenge.
That's a great point. And I just the intricacy of rhinoplasty, it is truly an artistic operation. I can literally, I have unfortunately, many times I have a short little attention span in life and in surgery, and doing a long 3 or 4 hour case on the breast or the abdomen, it's, after the 3.5 hour mark, it just gets a little taxing. But I could literally look under the microscope or look under my loops in a headlight at the same spot on a nose for 4 or 5 hours and not and still be engaged. I mean, it's just a beautiful operation. I do truly enjoy it. Now, the other important thing to talk about with this patient is the function, of course. So clearly, her initial issue with the otolaryngologist was breathing. Obviously, you can see how her nose is fairly constricted, what Dr. Jejurikar and Dallas referred to as the internal nasal valve. That was quite obstructed. She also had on the inside of her nose these fleshy little pieces of meat called the turbinates, which were quite large. And so the combination of having large septal deviation, turbinate hypertrophy, internal nasal valve obstruction really made her breathing very challenging. So our goals with this operation are not only to make this beautiful young gal look better, but to help her breathing and help her athletics and overall help her life for breathing. All right, so why don't we go into the post-operative result here? So this is her, and I truly believe in the fact that not to diss on many of our plastic surgery colleagues along the country, but you see in Instagram, a phenomenon of shooting on-table results right afterwards. Here's, I'm the expert in this breast surgery, and this is what the breasts look like on the table. But I think the true test of time is key. I really only want to shoot these results at a year, and this is a year. Okay. And, I think that tells us what happens to the nasal tip afterwards. It tells us what happens to the shifting of the pressure of the skin on the nose after a year. So what I did in her is we made a little incision at the base of the nose right here. I lifted everything up to expose it, and then basically straightened out the septum. I removed a substantial portion of the septum very safely, and we put that extra septum on the back table to use for spare parts, if you will. I also did a bilateral, what's called a submucosal turbinectomy, so we don't damage the function of the turbinates. We just simply make them smaller. And then I did a series of maneuvers where we cut the bones of the nose and break them to widen the base of the nose a bit and open up this nasal passage, in addition to reworking all of this cartilage at the nasal tip here. And that involves putting a graft at the tip of the nose to maintain the legs of that tripod, as Dr. Jejurikar and Dallas mentioned, and then adding a little bit of cartilage along the nasal rim, just a smidge, to help maintain this tripod appearance. So why don't we just run through and I'll come back to these. So this is her oblique view on the left side, oblique view on the right side, and then side views. And then, of course, the worm's eye view to things here.
It's a very dramatic change.
Yeah.
I'm sure she loved that transformation.
Yeah, it really balances out her face. It's very harmonious. And I think it also shows some of the things you wouldn't necessarily understand when you first look at a patient, is that you actually have to widen the nasal bones in order to, you think she has a huge nose, but you actually need to do that in order to achieve more cosmetic harmony. You see her tip and, all of the tip shaping that you did there to balance out her nose and to make it look, but you didn't overdo the tip. So a lot of what you see with bad rhinoplasties with celebrities or sort of in Hollywood are these, crazy snub tips that look really tiny and are totally pushed up. and she has a very natural tip shape, which is balanced and harmonious with her face.
And I'm sorry if I missed it. What did you say you did for her internal nasal valve? Did you do something for that?
Just out fractured the nose.
Okay.
And then with the so basically out fractured the nose, did some osteotomies on the sides here,
Okay.
and spreader grafts essentially to.
Okay.
Yeah.
Okay. Yeah, and that's the thing. One of the things Dr. Pacella did are things that you don't even see on this patient. He put grafts between her septum and the cartilage up high. I bet her breathing is dramatically transformed, even though her nose looks smaller. Yeah,
huge difference. Yeah,
that's a huge change in both a functional and an aesthetic manner for this patient.
Right, and one of the areas, one of the yardsticks we want to look at after surgery and on the table during surgery is this area right here. This is what we call the dorsal nasal aesthetic lines. And you can see in this patient here, and this should be a gentle slope from the tip of what we call the radix here in between the eyebrows to down to the tip of the nose. And you can see here, she's got a pretty dramatic triangle sitting here preoperatively here. And there's a break in that contour of the nose. And then afterwards, this is just a gentle curvature of the nose sitting right here in a relatively straightish line. And to me, that's a huge yardstick that I look at on the table to make sure everything is straight and to make sure the aesthetics is perfect.
Technical question: when you do your osteotomies, do you do them internally or do you do external osteotomies?
Excellent question. So, I just want to hint at the pedigree that we had at the University of Michigan. So, Dr. Jejurikar and Dr. Rhee both trained with me, obviously, at Michigan. We had a tremendous amount of training in rhinoplasty. One of our professors, Dr. Haskell Newman, was one of the founding members of the Rhinoplasty Society. We also had some expert tutelage by a gentleman named Dr. Robert O'Neill, who was one of the pioneers of rhinoplasty. And so this is an area of plastic surgery where we really have a fantastic, I think, background. And what you're referring to here is, I'm sorry, what was the original question? I just kind of went.
I was like, where is he going with this?
You are awesome. No.
External or internal nasal osteotomies? You do the approach.
Okay, that was what I was going. Okay, so Dr. Newman taught us the technique of external osteotomies. Okay. And what he's referring to is when you break the nose, how do you break the sides of the nose? Well, the external osteotomy is a procedure where you make a little cut in the external portion of the nose and use a tiny little plate, a sharp little chisel, if you will, to just gently fracture this area here under a controlled fashion. And I would say that for the first 5 years of my rhinoplasty practice in San Diego, I did external osteotomies. And quite honestly, I just, although we had great training in that, it's just something where my evolution has shifted substantially. And I just don't feel like I got great control of fracturing that area. And it was very difficult for me to fracture out a little bit laterally. So now what I do is an internal lateral osteotomy. So I'm oftentimes right near the turbinates, and where I do my submucosal resection of the turbinates on the inside, I just basically pass an osteotome underneath here, and it really allows me to fracture quite laterally. I think what this has really allowed me to do is when we had more medial or more central osteotomies, I would see this kind of box-like deformity to the nose. People oftentimes have this bony prominence here that is pretty aggressive when they have a large dorsum. And so allowing me to do the internal osteotomies, I could fracture that out a little wider and just get a better shape in this transition zone. Guys, your thoughts?
What was the question again? Yeah.
Internal versus external.
No, I know. Yeah, I was fortunate. I agree with all of your thoughts about the quality of our rhinoplasty education at Michigan. I was fortunate enough that when I went to New York after Michigan, I trained under with Nick Tabal and Sherelle Aston, who only did internal osteotomies. And then when I joined a practice that had Steve Bird and Rorick in it, and so there's no consensus on this question. I do a combination of both, but probably 90-10 internal osteotomies over external.
It's funny. It's funny because I trained the same way you guys did at Michigan, and then when I was at UCLA, we did internal nasal osteotomies, and then I did it both ways for a while. Now it's 90-10 for me external, and I just feel like I know what Sal's saying about getting that control, especially if you have to bring it out the nasal bone. But I just feel like, different tools, whatever you feel comfortable with.
Right.
There's like Sam said, and there's no consensus, and whatever feels good in your hands, and as long as you achieve the results you want to achieve. That's why I asked, because there's no necessarily good answer for it. It's what you feel comfortable with.
You clearly, I think one of the artistic aspects of plastic surgery, cosmetic surgery of the nose and face is, you have to have different arrows in your quiver, and not every arrow is going to accomplish what you need. So, and that's, the broader you're trained, the more tools you have in your toolkit, I think the better. So.
I think the other point that you made, I'm as guilty as anyone else about posting on-table results for certain types of procedures, but I've admitted it's social media.
I do it all the time. It's what's expected in the current age.
Right. But for rhinoplasties, you cannot. And I do counsel patients. It takes a long time for that swelling and for that final shape, especially for the tip, to come into focus. And it's one of those that takes some patience, especially when you're doing a fairly big rhinoplasty, as you did here, for the final post-operative result to show. Like, I don't think anyone should show an on-table result for rhinoplasty. I think most of those should really be reserved for, long-term results, because that's really, like you said, where you're going to see it.
Yeah, I think it all depends on the purpose of showing that on-table result. Let's be honest. Half the time it's on Instagram, it's to say, look, I do rhinoplasty.
Right.
So,
that is true.
That's really the purpose behind it. You gotta have
hashtag Instagood.
Exactly. Well, that was an excellent result, Dr. Pacella, and an excellent presentation as always. I always feel a little bit smarter after I talk to you, gentlemen.
Same, absolutely. That was an awesome case, and really, really fine result. I'm sure that patient functionally and cosmetically was thrilled. And the fact that she's young and was able to do it at an age where I think she's going to benefit for decades. This is going to be something that was life-changing for her in so many different ways, which is really what our goal is, right? We really want to make such super positive changes in our patients' lives.
Great. Well, I think on that note, let's call it a podcast, gentlemen. Thank you as always, and have a wonderful week.
Great. Thank you.
All right, gents. Take care of yourself.
Take care.
All right.